Good afternoon, everyone. Welcome to the Penn State College of Medicine COVID-19 and Regional Skilled Nursing Facilities Echo Series. We're delighted to have you join us for this session. My name is Jackie Sable. I'm a member of the Echo team. I'll start us off with a few announcements and introductions, and then we will be passing things off to Dr. Ahmad to facilitate our session. A few quick announcements. If you've not already done so, please put your name and email address in the chat box for our record-keeping purposes. Please stay muted unless you're speaking. You can use *6 on your phone or the microphone icon on the bottom of your Zoom screen to mute and unmute. We also encourage you to use chat for communicating, and if you have a webcam, please feel free to use that as well. We know that Q&A time is important, and we will try to address all questions that come in. If there are any questions that do not get answered, we'll follow up. We're recording the session, and we share all material and recordings after the session. In the spirit of Echo's all teach, all learn, we're on a first name basis during this session. Please remember that if we do start talking about patient cases, no personally identifiable information is.
Well, anyway, I need you to ignore this and be happy. You'll be fine.
Mute that one. There we go. Sorry about that. So today's session is going to include a brief lecture, and I believe it's going to be a little bit interactive on advanced care planning and serious illness conversations in the era of COVID-19 pandemic. That'll be led by Amy Westcott and Lois Chappell, and it'll be followed by discussion and Q&A facilitated by Aisha. So during the lecture, please feel free to go ahead and put your questions into the chat. We have a team online that'll help field questions. We'll also discuss those afterwards, but remember, it's all teach, all learn, so you can share both questions and answers in the chat. In the interest of time, I'm not going to have everybody introduce themselves, but I would ask our lecturers and our facilitator to go ahead and introduce themselves as they start their parts. And with that, I'm going to start the screen share and give control to Amy, who will start us with her lecture. And Jess, if you can go ahead and mute me so I don't lose anybody while I'm doing this for Amy, that would be wonderful.
Great. Well, thank you very much for having us. My name is Amy Westcott, and I'm the Medical Director of Transitions of Care for Capital Blue Cross, and I also wear a hat as an Associate Professor at Penn State in Hershey. And I was asked today to talk a little bit about the experiences that I had when I was the Optum Medical Director with a lot of advanced care planning discussions in the nursing home setting around the pandemic. Lois Chappell is with me today. I'm not sure, Lois, are you signed in yet? I'm hoping we get her audio. And I've asked Aisha Ahmad, who's running this series, to also chime in as we get rolling. We do not have any financial disclosures. And I have a very sensitive mouse button apparently, so it's flipping through the slides quickly. So our objectives for this session today are threefold. Describe the unique concerns of residents and families when discussing goals of care, especially considering the COVID-19 infection, as well as the post-infection decline that we see in some of our patients, review and how to help the families cope with that. So we're having patients die, not necessarily during the acute phases of the infection, rather the complications or afterward. Review best practices for serious illness conversations, especially in long-term care around the pandemic. And utilize communication techniques during the pandemic that are valuable. And I'm sure many of you have had your own experiences, and we're looking forward to sharing some of your pearls of wisdom with us today as well. So one of the common language techniques we hear about in the literature, and we hear about is practicing pocket phrases when we're talking with patients and families about serious illness. So I wish things were different. However, I'm worried that your mom is not going to do well, and saying why. So the I wish, I worry is one of those easy techniques to remember and have in your back pocket whenever you have to have a serious illness conversation. These are really difficult conversations. They're not just only difficult for our patients and families, they're also difficult for us as healthcare professionals. And it's really important to remember that and to think through how to prepare for the conversation before going into the conversation. It seems very commonplace to say this, but focusing on quality and individual choices, being very goal-directed. What would this member or patient or family want to get out of this given situation? And sometimes it's not black and white, and there's a lot of gray. And how do we navigate that? And how do we help get them where they want to go in a way that they're comfortable with? And, the goal is to improve patient outcomes, to be personalized and patient and family centered. And I think that's, really hard sometimes for us to do, especially in the context of the pandemic, where we've seen shortages in PPE and testing and all those types of things. And how do we navigate that and maintain the trust of our patients and families? And another technique that we use is tell me more. So tell me more about what you're thinking. Tell me more about your mom. Tell me more about how you'd like this scenario to go. Another one is ask, tell, ask, and I wish, which we talked about, I wish, I worry. So these are all techniques that you can look up, and they may come out when we do some role plays today. And I just wanted you to know about them. And Lois is trying to connect. Let's see here. Jackie, do you think you could send her an updated calendar invite just to make sure she has the correct information?
I can do that since you're sharing Jackie's screen.
Okay, that'd be great. Okay. All right. And I'm going to put at the bottom of all of our slides, we put references to the places that you might want to go to look for scripts or things to practice on your own or to read about and think through. I have found over my career just reading things and thinking through how I'm going to talk to a family before I have that conversation and having some pocket phrases to be very valuable. So Ariadne Labs has a lot of tools, and they even have some videos on their website, things that you can think through ahead of time, and you can use them as teaching tools as well with any learners that you have. So these are crucial conversations, and research is still developing in this area, again with the focus on improving patient and provider communication. And in the context of this pandemic, as I alluded to earlier, there's that pre-COVID conversation. So, we think how would you like us to plan to care for your mom or dad should they contract the virus? And, there's a whole spectrum of responses to that. I know Aisha and I talked about some cases where a family said, you know what? I know I said comfort care, but I don't want my loved one dying of the coronavirus. So I think they should be a full code. And then you have families that say, oh my goodness, I know they won't do well, and I don't want to put them through that. And also, the limitations on visitors and people in hospitals not being able to have visitors. And so having their loved one die alone in the hospital is not what they're interested in. So really trying to think about the nuances, and it can be different based on where you're practicing. So, if you're practicing in, when we were at the height of things in New York City, it was, very different resources as compared to central Pennsylvania, for example, and so how we manage things can be very different based on where you're practicing and your health system that you're working closely with. And there can be barriers to trust and relationship that already exist. As we know, the nursing home world is very complicated, and long-term care and personal care and assisted living, there can be a lot of trust issues, not just amongst the healthcare providers, but the staff in the home, or they might not, family might not be happy with the level of care their loved one's getting. And so there's a lot of complexity that goes into the conversations that you're having as in advanced care planning that aren't necessarily related to, their loved one's healthcare, right? So I think that's another layer that we have to think about when we're having these conversations. And then some of the techniques are, to provide short stories, examples of things that have happened that you've already seen during the pandemic, being very emotionally based, supporting them, using your techniques to provide, empathy. And then I'm going to role model the calmer method, which is from the Vital Talk, when I do one of the role plays with Lois. If Lois is on. If Lois is not on, then Aisha, you're going to be doing role plays with me today. Let's see if Lois is on.
I'm cool with that.
Okay. Lois, are you on? Do we see her signed on?
She looks like she's signed on and unmuted. I mean, her name is showing up.
And I think I saw a message earlier that she had logged on, right?
Right, and she chatted with me just to say to let her in. So she had to have been on at least a little bit. I apologize. I'm not sure what the problem is.
Okay.
Amy, you can tell me what I need to do.
All right. So this is Lois's case. So she had a couple who reside in a long-term care together. And before the coronavirus entered the nursing home, she had a conversation with the both of them, as well as with their daughter, who is the decision maker. And she, wanted to make sure that there was some plans in place should the virus come into the nursing home, what would their goals be, right? So this is probably like 2 weeks before the virus got into their nursing home. So if you could please be the daughter. And I believe they both were cognitively intact, Aisha, and were able to make their decisions and what their wishes were, and they had very differing thoughts on it. So I believe her dad wanted to go to the hospital and the mom did not, or vice versa. So we can play it either way. All right, so I'm going to role play with Aisha. Aisha's going to be the daughter of this couple in the nursing home. So Aisha,
just to be clear,
yeah, go ahead.
both are cognitively intact and both are
yes,
able to convey their choices.
at this time, in this moment of time, yes, because they lose it later.
Okay.
Okay, because they get sick. I'm telling you a little bit. So, all right. So Aisha, this is Dr. Amy. I'm calling you today to talk about your parents. Given the pandemic and everything that's going on, how are you doing with all of this?
Well, I'm really worried because I can't go and visit them. And I have no idea how they have been doing recently. And I know they're high risk. And I'm really worried that if there's an outbreak in the facility, I'm not sure what would happen if they were to get COVID.
Yeah, I can't imagine what that feels like not to be able to visit them on a regular basis. I know you're very involved with both of them. How have you talked to them at all? And how have you been thinking about the COVID situation and in the context of your parents?
If I lived in the state, I would have brought them home. I'm really worried. And I know they're really worried too. I know that the facility is doing its best to limit visitors. But who knows? I've heard from other facilities that a virus can get in through caregivers. They're not going anywhere. So I'm just, I don't know, Dr. Westcott, can you tell me what are their chances of getting COVID?
I think you asked a really good question, and we're not sure. I know you've probably seen in the news that, it can get into a nursing home and spread very quickly. And now we know more about it than we did before, but it's something we need to be prepared for. As you mentioned, it's a possibility. I agree. Is there is there anything that you want us to know about your parents if they were to get the coronavirus or if they were to get really sick from it? Have they mentioned to you what they would want for their health care?
Oh gosh, we've never talked about that. I never thought that would happen.
Would it be okay if I share with you what I've learned from talking to both of them?
Sure.
So I'll say that when I talked to your dad, you know, he has a really good quality of life here with your mom, and they're very, very happy. And he says that he would prefer to go to the hospital if something were to happen. We talked through the chances of getting short of breath or really sick, and he said that he would be interested in going to the hospital. When I talked to your mom, though, she has a very different perspective, and she says that she would prefer to stay here at the home where the staff know her and be surrounded by people who would take good care of her here. When you hear about both of them having different thoughts about it, what do you think?
Well, first of all, I mean, I worry about Dad. If he were to go to the hospital, would he get exposed to more COVID-19 virus? Will they really be able to help him? What if he needs to go on a ventilator?
Yeah. And those are very real concerns. We have seen a lot of our older adults that have to go into the hospital not necessarily do well. And so that's one of the concerns. You know, if they're not able to make decisions, they have you listed as their power of attorney. Are you still comfortable with that?
Oh, darn it. I'm not, but I guess if I have to take that responsibility, if both of them get too sick, I have no choice, I guess. Now,
This can be really hard.
Sorry, go on.
I was just going to say, this can be really hard to think about.
I know, and then I worry about my mom. I mean, if we don't hospitalize her, should she get the virus, does that mean we're just letting the virus, you know, take her? Does that mean we should have done more for her?
And that's a great question, because what we know is that in this population, the virus can be deadly. And the treatment options are truly supportive care. At this time, I mean, we're very lucky now. We know that sometimes people do well with steroids you might have heard about. Unfortunately, we don't have any true treatments that attack the virus yet.
Oh, it's like I have no good answers to my problems. Dr. Westcott, you tell me, what would you do if my parents were your parents?
That's a really, really tough question to answer. At this time, after talking to both your mom and your dad, I would recommend that we adhere to their wishes, that your dad has said if he were to get sick, he'd like to go to the hospital. And I'd like you to think through what could happen in the hospital, and you know, if he weren't to get better in the hospital, how you would feel about comfort care should that need to be discussed. And then with your mom, I feel comfortable having talked to her as well, supporting her here in the nursing home and talking to you if she were to get really sick and not be able to make decisions, and we could have some real-time discussions about what's best for her. So if it's okay with you today, I'm going to document this conversation, and then we're going to take things as they come. And I'll be rounding here regularly and be able to reach out to you as things change.
Wait, Dr. Westcott, what if my mom were to get COVID-19 and then she gets so sick that she needs to be on a ventilator? How can you provide her that in a nursing home?
We cannot provide that in the nursing home. That's a great question. Nursing homes can provide oxygen, IV fluids, antibiotics if needed, the steroid medicine we talked about is needed. If your mom were to get short of breath and none of those things helped her, I would be talking to you about comfort care and recommending morphine.
Doesn't that mean I just let her die?
She would be dying from the coronavirus.
Oh, that's a tough one.
It is a tough one. So I'm going to pause here, Aisha. So I would love to hear from the group, you know, what went well, what could have gone differently, or any pocket phrases when you hear us having that conversation. Does anybody have any thoughts or comments?
Maybe they'll put them in the chat. I think while people are gathering their comments, one of my scenarios that often stumps is when people say, oh, does that not mean that you're just gonna let her die by not intervening? I think those are the questions that are always difficult to answer when people equate comfort measures with you actually hastening or facilitating death.
As opposed to it being a natural death due to the complications of the virus. Because I think that's a common misconception. I mean, we all are going to die of something, right? But how do you communicate that with a patient or a family? And especially since this virus has been so unpredictable. You have patients that are asymptomatic, and then you have patients that get really sick from it. And you don't know who's going to fall into which bucket. So I can tell you with this scenario, the husband went to the hospital acutely short of breath, was diagnosed with the coronavirus in the hospital, and subsequently died. And the family had to get called back in and, you know, talk about it, and he was made comfort care. He never was intubated. And then the wife got it because they shared a room, and she was symptomatically treated. And, you know, they had a conversation about how to manage things. And so the daughter was definitely worried and bringing up all the things that you did, Aisha, about, well, what can we do in the nursing home? And I think that's the key point here, is that we can do so many things in the nursing home that, you know, years ago we couldn't do, like oxygen, you know, steroids, IV fluids, antibiotics if needed. And so her mom was cared for very, very closely in a closed coronavirus unit in the nursing home, and did very well. So she was treated in her home, surrounded by staff that knew her, and survived the virus. And so this case scenario of this couple, I think, is a really helpful one for us to think about, how there's so much unpredictableness with the virus and how it's going to play out, and how one family can have two different outcomes.
But in a way, LP's outcome was great because she did better while everyone did what was aligned to her wishes. And poor Mr. RP's outcome was not good, but we all follow, I guess you all followed what he wanted. So in that way,
yep,
there was no conflict. But I think the harder thing would have been, let's say either the patient or the daughter would have wanted to send to the hospital, do everything, and the patient would have died anyway.
Right, and I think that's the hard part with these conversations. Does anybody in the audience want to share any case scenarios or conversations they've had, or key phrases that are helpful? Aisha, are you able to see the chat box?
I am, and no one is putting up any new comments or questions.
Okay. Well, I can keep talking. So what I used when I was talking to you was the calmer method that comes out of Vital Talk. They have a very nice COVID-ready communication playbook, and it talks about, different ways that you can do things, and it has acronyms, which if you're somebody who needs help with thinking about things in a systematic way, the acronyms are very valuable. And so I really like that one. That is the CALMR is used for the contingency planning. So the pre-coronavirus infection planning conversation, which I would encourage to be happening in every nursing home member if you haven't had that conversation already. I don't know, Aisha, if your practice has been able to do that.
I think because of outbreaks and almost, well, in many of our facilities, we've had the conversation, but we have not followed a certain paradigm, certainly not the crucial conversation paradigm that you're talking about. Although I've heard of it from, in terms of conflict resolution for other problems, but never in regards to COVID-19.
Sure, so somebody asked me what the acronym stands for, so I'll let you know. The CALMR, the C is the check-in, so that's that, how are you doing with all of this question. A is ask about COVID. What have you been thinking about the coronavirus? L is lay out the issues. So here is something I want us to be prepared for, right? And I think this is where you need to use the D word, that their loved one could die from this. They're probably aware of it, but I think we avoid the D word a lot, and this is a place where we need to be honest and raw. M is for motivate them to choose, what their decisions are or lay out a proxy. So if you're talking to a resident in the nursing home, you might say, I need you to designate somebody, or I want to double check that this is who you'd like to make decisions for you. And if there's any contingency that they want to put in their record. E is expect emotion. So many family members have cried, many nursing home residents have cried having this conversation because it's really hard to think about. I mean, this is unprecedented in our lifetime. So expect emotion, and you might be able to say to them that phrase, this is hard to think about, acknowledging it. And R is for record the discussion. So document anything that you think is helpful and let them know that you're going to document anything that you think might be helpful. So that's the pre-COVID discussion. Now, breaking news. Aisha, you want to do a breaking news with me?
Sure, tell me what I need to do.
Okay. How about you be here's the scenario I had. An 88-year-old woman with dementia in a wandering unit, in a guarded unit, and she likely has the virus. And you're going to be the daughter from out of state that I'm going to call to check in. And the members' goals, the patient's goals have always been comfort care, but the daughter we're going to talk through a little bit of how do I break this bad news, and how do we navigate what comfort care would look like in the nursing home. Okay?
Okay.
All right. And feel free to throw any curveballs if you want to at me, and we'll see what happens and debrief it. So,
sure.
Aisha, this is Dr. Amy. I'm calling about your mom today. Is now a good time to talk to you?
Yes, I'm available.
Okay. I know that you haven't been able to see your mom in a while because of the pandemic, and that you're out of state. When was the last time you got an update from the staff about how she was doing?
I think it was about a week ago.
Okay, and how was she doing?
Well, the staff said that she continues her dementia-related pacing. She likes to pace all over the unit, and sometimes she's in and out of other residents' rooms. I don't think she's eating that great. I think one of the nurses said she has lost 3 or 4 pounds, but you may want to double check that. It's very hard for me to talk to my mom because she really cannot have a phone conversation with me, or FaceTime doesn't work either. So I really have to rely on the nursing staff.
And it's good to hear that you've been getting updates from the staff. So I'm calling today because I'm concerned that she might have the coronavirus. There's been an uptake in our county of cases, and your mom is having low-grade fevers and a cough, and I'm worried that she might have the virus.
Oh my God! So have you done the COVID test on her?
So I'm calling you to let you know that I sent it. It might not come back for a little while. So I'm going to treat her as if she has the coronavirus. How does that, yeah.
So I'm really concerned. Should we send her to the hospital, Dr. Amy?
That's a really good question. And that's why I wanted to call you and talk to you about it. Given that in the past, when your mom has had aspiration pneumonias or urinary tract infections, we've managed her very well here in place. We've been able to give her IV fluids, IV antibiotics, or oral antibiotics, and she usually turns around because the staff here know her really well in her unit here. So I'm thinking that with the coronavirus, we probably should do the same thing. I don't know if you've seen the news, but you know, when somebody like your mom goes to the hospital, sometimes they end up isolated. They don't allow visitors. They're not cared for by people that know them. And I think she has a higher likelihood of surviving the infection if we keep her here.
Wait. No, Dr. Amy, I don't know what you've done. I know what you've done for her in the past, but this is a COVID-19 virus. So many people all over the country are dying from it in nursing homes. I don't want my mother to die. I know she has dementia, but you gotta help her. You gotta send her to the hospital, do whatever it takes. Please give her some hydrochloroquine.
You know, Aisha, you bring up some really important points, and we're still learning about this virus and how to treat it. If your wishes are to send mom to the hospital, I will totally support that. I just need to make sure that you're aware that hydroxychloroquine has not been shown to be helpful, and that we can do all the things that have been shown to be helpful, like steroids, oxygen, fluids, any medicine for her cough. We can do all that here for her.
What if her breathing gets worse with the oxygen even? What would be the next step then?
So the next step would be to focus, if she wasn't doing well, would be to focus on comfort, because in the past, you and her have not wanted to do, you know, a breathing machine or heroics. And you guys have made it clear that mom would prefer a natural death. And so coronavirus might be a natural death for your mom.
Oh no, Dr. Amy, I'm not ready for my mother to go from this virus.
Okay, and so I'm going to put that in our contingency plan. And what I'm going to do is I'm going to treat her with all the things that I have in my toolbox here in the nursing home. And then you and I are going to touch base every day, or the staff are going to touch base with you to see how she does. And if she needs to go to the hospital as of right now, then that's what we will do.
Well, do you think the nursing home has the staff to take care of her right now? She's so sick.
That's a really good question. And we had a huddle this morning with all the leadership here because we're concerned about more residents coming down with the virus. And we have the staff, we have the backup staff, we have a plan in place. We have all the medicines that we might need from the pharmacy. We've been really preparing for this, and we have all the personal protective equipment as well. So we're in a good place now. You know, having learned from other communities and nursing homes, we're ready.
But Dr. Amy, how did she get the virus? I'm going to talk to administration. I'm not happy with this. Who gave it to her?
We don't know yet. We're in the middle of doing an audit and doing some contact tracing to try to figure out how it came in. As you have seen, that it's a highly contagious virus, and so we're not sure how she got it yet.
Oh, please call me every day, Dr. Amy.
All right.
Amy, I just want to let you know, it seems like Lois might be in. Can you hear us?
I don't hear Lois.
I know, we can't hear you, Lois. I don't know. You're unmuted. I'm going to unmute you. I'm not sure why we can hear. I just wanted to interrupt and let you know she's trying really hard. We don't know what's going on. But thank you, Amy, and
That's
thank
okay.
you, Aisha.
No problem.
That's all right. So Aisha role modeled beautifully the challenges that family members are struggling with during the pandemic. And then as the provider and the clinician, how hard do you push, right? Like you don't want to put your thoughts and opinions on somebody else's goals of care. And so the thing that I didn't do, Aisha, on that conversation when I reflect on it, is I didn't give you my recommendation. So if I had given you my recommendation, do you think that would have changed your thought? Like if I had said to you, well, Aisha, I've known you and your mom for a year, and I would recommend that we treat her here. How would you have felt about hearing a recommendation?
I think putting myself in the daughter's shoes, well, first of all, you know, your demeanor in both these scenarios was so calm. The first child was realistic. The second child was definitely looking for outcomes that were probably not congruent to the mother's quality of life. So I think you carried it beautifully. I think no matter how unreasonable my demands for my hypothetical mom would have been in this case, I think if you had told me this is what I think you should do, would have probably you would have made me, what's the right word I'm looking for? I think I would not have appreciated that. And I probably would have pushed harder for a hospitalization. So the way you handled it actually made me think of keeping her in the nursing home, at least as a trial period. And then I like the way you approach the contingency plan.
And I think that's where you develop trust with a family that's struggling is, you know, a trial period is a great technique to say, let's try this for a period of time. Let's see how it goes. And if she makes the turn, we'll send her out. And that's where you have a conversation with the hospital she goes to, and you let them know about what the conversation was so that the person making the decision is supported. And I think the recommendation piece is very tricky, and you have to know your family as to which way they would go with the recommendation. So Aisha felt like the recommendation would fall short. Whereas some families want that recommendation. They want to hear what would you do if it was your loved one, right? So sometimes I'll ask permission. Would you like to hear what my recommendation would be? And sometimes just asking that permission kind of sets the stage and kind of brings the anxiety down a little bit. And then the other piece is sharing stories. So, you know, you might be able, like I was trying to share stories about how the mom did well when we treated her in place in the past when she had her urinary tract infection and her aspiration pneumonia. Give other examples of when she did well being treated in place to try to help the daughter's anxiety go down a little bit, knowing that the team had taken care of her before without going to the hospital and she did okay. I think the flip side of this is that this is a very different virus. This is a deadly virus. It's not necessarily like having an aspiration pneumonia. And so the conversation I did not have with Aisha, because it wasn't ready, Aisha wasn't ready to hear this. But one of the things when you're diagnosing somebody with coronavirus that's important to have is that if they don't do well tonight, so many of you on the call have been taking care of people with the coronavirus, you might diagnose it that day or suspect it, and they don't do well within 12, 24 hours. And so when you have that diagnosis discussion, also having a very a heart-to-heart conversation about should they not do well, which, you know, how would you like me to treat them? And that's where morphine comes in and comfort medications, because it is such a fast deadly virus in this population. So those are my kind of thoughts and caveats about breaking the news of the coronavirus. Aisha, do you have anything else to add before we go to the post-COVID situation?
I think the hardest deaths, at least for our teams in the nursing homes, were the people who were getting better from COVID-19. They were in their second week and boom, they died unexpectedly, not from progressive hypoxia, pneumonia, or dehydration, but from what we think was a sudden cardiac or, a sudden cardiac event, a stroke, or a PE. We can only presume much.
Yep. And that's where this post-COVID conversation comes in. We saw a lot of cases where people just even had the dwindles, so to speak, right? That there's no scientific term for the dwindles. But people who just, they lost their taste and smell from the virus and never recovered and stopped eating and didn't do well. And, 2 to 3 weeks out, you're having a comfort care conversation with their loved ones because they weren't dying of the acute phase of the infection, but they were dying of the infection, the repercussions of having had the infection. So how are we doing on time? Maybe we should keep going. Do you want to role play this one real quick?
Dr. Amy, can you hear me?
Oh, I think that's Lois.
I dialed in for a third time, but Aisha, you are doing wonderful. Why don't you finish up this scenario and then I'll help with what I can at the end.
Sure, Lois, you're more than welcome to take the third scenario, because now we can hear you loud and clear.
Thank you for your patience.
So Lois, do you want to be the person to have the conversation or the loved one for the post-COVID decline?
No, I'll be the daughter. I'll try to take over from Aisha's really great performance there. Thank you.
Okay. So do you have a member scenario in your mind that we might role play?
If you want to just kind of play out the family that we both know so well, this family, and just change some of the dynamics, I think that would work, really well.
Okay, so let's say that the mom, she survived the acute illness, right? She comes out of the COVID wing at the nursing home and she's lost her husband to the virus. She's now alone in a room and she's kind of got the dwindles a little bit. She's not doing well. She's not eating well. And now she's developed a bed sore. Let's say that. Okay. So Lois, it's Dr. Amy again. I'm sorry to bother you today, but I wish I had better news, but I'm worried about your mom after, everything she's been through. Have you touched base with her? Have you seen her? I'm sorry, I shouldn't say that because you're not seeing her. Have you touched base with the staff?
Oh, well, the nurses are really good, and they do try to call me, every couple of days, and they told me that mom doesn't have a fever and that she's breathing okay.
And that's correct. And you're aware that she's out of the COVID wing?
Yes, we're so happy. Thank you for your help in getting her to survive COVID. We were so scared, and you did such a wonderful job. Thank you, Dr. Amy.
You need to know that the team here has really put a lot of effort into managing that COVID wing, making sure we transition people out of it appropriately. However, I have to let you know that even when people are surviving this acute phase of the illness, we've been having some people not do well in the weeks to months after the virus.
I did see on TV that the nursing homes aren't really doing a very good job taking care of people. Do you think that's what happened to my mom? Do you think she's not getting good care?
So I have confidence in the home that they're doing a good job taking care of your mom. I hear that it's scary to be far away and not be able to come in and help do the care that you would like your mom to do it yourself, right? I think that's the hard part. I know that before the pandemic, you were in here regularly bringing your parents their treats, their special snacks, and spending quality time with them. So it must be really hard to be trusting the team in the home to do that type of care for your parents, for your mom now.
It's really hard when you can't see your parents. And you're right. You know, we were very involved. My brothers aren't there, but they would always call, and I could tell them what was going on. But not being able to see her, and you're right, eat with her and give her food has been really hard.
So I have to let you know that I am worried about your mom. I think she has some depression after losing your dad. It's been a couple weeks now. And I also am worried that she's not eating enough. And she's starting to have a little bit of skin breakdown, and I'm worried it's because she's not eating well, so that she doesn't have the right nutrients to you know, fight off any type of skin breakdown or infection. Has she ever had any skin breakdown before, Lois?
Not that I know of. Her skin's always been very nice, and she looks much younger than her age.
So I'm worried that she might be dying. She might have complications of having the coronavirus that are going to show up after the virus, and that she might not do well. So I'm worried about her right now, and I just want you to know that we're going to keep a close eye on her.
Amy, thank you for keeping a close eye on my mom. You're such a good doctor. Can I come in and see her? I think that would make me feel better if I could see my mom.
So one of the things that we've been doing is we've been doing window visits. And so we have a room that we can bring your mom to, and that you would be able to visit her through a window. It's not the total solution. We could also do an iPad visit if you'd be interested in doing something like that. Some of the families are finding that very helpful.
I would really like to do that. And I know if my mom got really sick and went to the hospital, I couldn't see her there, but I did see on TV that sometimes the people in the nursing home, you know, don't do well, like you're saying. Maybe I would be able to come and see her. Would that be possible?
And we've been figuring out ways to do that. So I will talk to the administrator at the nursing home and the DON. If we were to get to that place, we'll make sure we have contingency plans.
Okay. Is my mom in pain? Will she be in pain with what you're telling me?
She's not in any pain. I'm just worried that she isn't doing well. And we've seen some people die weeks after having the infection, some from cardiac events. You know, this virus affects the whole body, and we still don't know all the different things that it can do. And so I just worry about your mom. She's kind of got the double, you know, she got hit in two different ways, one losing your dad, and then the second with the coronavirus. And so while she survived the acute phase, I do worry about how she's going to do in the long run. And that's why I wanted to call you today.
Thank you. Yes, please keep me updated, and please tell my mom that I love her. My parents were married 66 years, and they celebrated their anniversary right before COVID. So I know she probably wants to be with Dad right now, but I really want her to know that me and my brothers love her and that we're fighting for her.
Absolutely. I'll be sure to share that with her today. Thanks for taking the time to talk to me, Lois.
Thank you.
So Lois, anything in the debrief that you have to add to the conversation that Aisha and I were having earlier?
Well, I will say that, you know, like most relationships, the beautiful thing about working with this family, because Dr. Amy knows this was a really hard case for me. I knew this family for a lot of years, but we developed such a deep trust through our monthly phone calls and meetings, you know, with the daughter, and occasionally she would call her brothers in, that she was not able to make her mom a do not hospitalize until mom was actively dying, which actually happened very quickly. And when I had to make that phone call, you know, it was very hard for me to make that call, to tell a daughter that her mother died after she lost her father, both from COVID-19. And this was very early on. in our area when this hit. But I think because of that trust, she was able to say, please just keep her comfortable. I know that you're with her, and I know that you're doing the right thing. And she did not get to see her mom, in her final days, but we spoke frequently after that, and she was really comforted by the healthcare team. So I really commended the facility too for, allowing this family to trust them that they were doing the best when it was so scary, what was going on through the media.
And Lois, would you share with us one of the techniques that our staff have found helpful if somebody is acutely ill? We found a really nice another acronym called LOVE, and this comes from Vital Talk, and it's helping families say goodbye.
Sure, yes, and this is from Vital Talk, and this is available in many, many languages, so that you could use this with a lot of different patients and residents that you might have. But it's an opportunity to give you, a template, like Dr. Amy said earlier, to prepare to talk to a family, especially, when you're tired, working a lot of hours during COVID, and we were all so sad too through this early time, that to have something to focus on and practice was really helpful. And so the L talks about leading the way in the conversation. And, of course, you'll use the prompts that are really comfortable with you. I think the most important thing for our families to know is that we're real. And it's okay for us to have emotions and stumble, a little bit too. I think this really displays our empathy. But especially if you're not really familiar, with the patient that or the family that you're calling about, it's really helpful to introduce yourself and like Dr. Amy and Aisha, they talk about, who you are and what your relationship is to the care team, and let them know that this is a really tough situation for most people, and that you're going to be there for them to help them work through the news that you're going to tell them. And you want to really, be pointful and clear so there's no misunderstanding. And then it's a good opportunity to offer 4 things that matter to most people that you'll encounter in these difficult conversations. It's often good to say, we have the opportunity to make this a special time as we're helping you to say goodbye to your loved one. And here are some things that you may want to say to your loved one. We could set up a telephone visit or a video conferencing, but most families and loved ones find it comforting to say something that they've been wanting to say, that really holds true to their heart when someone that they love is dying. And there are some examples here, such as, I forgive you, I thank you, I love you, please forgive me, or goodbye. And if you offer these little snippets of communication to the family that is trying to, grasp and accept that their loved one is dying, it will give them the opportunity to say goodbye. And then validate what they want to say. And you can even practice like we're doing now, with that loved one, or just be with them on the phone while they say these things, and have that opportunity to say goodbye and have some peace. And you could say, I think that is a beautiful thing to say, or something like, if my daughter were to say that to me, I would feel very valued, very touched, very loved. Also, if the patient is, actively dying, you could always help the loved one feel better by saying, I think that they can hear you, even if they can't say anything back. And sometimes you may need to prod them along a little bit because they are sad or they are scared. And we all know there's difficult relationships, so it may be a very hard time for them to be open and loving with the person that's dying. So to encourage them to just say one thing at a time, to take their time and allow them time to cry and mourn and grieve. And then, with all of our conversations, you want to have a wrap up. So the E in love is for expecting emotion. And I think it's important for us to validate that that we were aware that this special person that's dying meant a lot to the person that you're helping, either on the phone or in person. and ask them, you know, if you could spend some time with them and see how they're doing, offer them some comfort, check in. And as my team did with this family, we followed the daughter for a couple of weeks. We sent a sympathy card. I actually just went out to call her again the other day, so I'll probably call her this weekend just to tell her how special her parents were to all of us, because they truly were a beautiful family. So does anyone have any questions about using the love technique? Or any examples when you've used something similar to this?
All right, so we have just a couple minutes left. I'm going to wrap up with a summary. Lois, you and I can kind of tag team it maybe. I would say that at the end of the day, if we keep our advanced care planning discussions focused on patients and families and what their goals are, that's kind of the way to help things move in the right direction. I do like to consider using recommendation language. As you saw in our role play, it might have fallen flat with the member, with Aisha and I when we had that one daughter. And I think these are some helpful phrases. Thank you for sharing what that with me. I'd like to reflect together on what you've shared and make a plan for moving forward. Would that be okay? So it's asking permission to give that recommendation. I've heard you say that your mom is really important to you based on your priorities and what we know about your mom's illness and this current situation with coronavirus. I would recommend this. And so I do think that it's important to think about, and you have to gauge that patient and that power of attorney or daughter, whoever's making the decisions, whether or not they're comfortable with the recommendation language. It is helpful though in certain situations. Important to allow times for questions and grieving and listening. The silent pause is always helpful. Count to 20 in your mind and just be quiet and see what they say. Sometimes people break down and cry when you give them the opportunity of silence to really think about what's going on. It's important to debrief with the family, as Lois talked about. She's been debriefing with this family. If you can, or your other parts of your team, members of your team will debrief with the family, and debriefing with colleagues. I know over the past couple of months, I've debriefed many challenging cases with Lois and Aisha and other care providers to think through, the language, what phrases would be helpful next time we have the situation, what might we have done differently, because we're all constantly growing and evolving. And then I think it's important to have follow-up and closure. And that can look like a variety of different things, like Lois just shared. She sent a sympathy card, could be checking in later, making sure you have your own outlet. A lot of healthcare professionals have taken to journaling during this time. So maybe having a journal where you can kind of write about these types of experiences can be very helpful for closure for the healthcare provider as well. Any comments on the summary, Aisha or Lois?
I was just wondering, Amy and Lois, did you have a slide about calmer as well? I know you have about love.
I did not put a calmer in there. It is easy to find if you Google Vital Talk.
Okay.
It's in the playbook.
Yep, it's in the playbook, and there actually are a lot of different techniques to use throughout the counseling and decision-making process. Yep, and we do have a link for that in this slide.
Okay.
Yep, the last slide has all the references. Yep.
Jessica, I wonder if you can you put the link for vital signs in your in the handout you share with the audience.
Yes, I would like to do that. Amy, you said that's at the last slide?
The last slide has all the references and the links.
Great. Thank you very much. We will make sure that that goes out to everyone.
Thank you so much, Amy and Lois. I think these talks have been hard. I wish I had access to this in the beginning of the pandemic, but oh well, it's not too late.
We still have an uncertain future ahead of us, so I think it's helpful for all of us to be thinking about it and be prepared, and let's hope we don't need all of it.
I know, and I think one challenge is when people think COVID-19 is different than other diseases, right? They somehow think either you should beat it or you shouldn't be, like they don't have a middle ground for it.
Mm-hmm. It is a very polarizing diagnosis right now, and I think what we're going through in America with all the other different polarizing things, it just makes it that much more challenging. So the time that we can take to listen and have thoughtful conversations will pay off in helping our patients do well and the families do well, because the families have to live with the decisions that they make, and at the end of the day, we have to make sure that they're comfortable with the decisions that they make.
Absolutely.
So there's a lot of weight in these conversations and making sure that everybody comes away and can sleep at night, right?
Right.
Well, thank you very much, everyone, for your participation today. It is 3 o'clock, and I ask that you watch for the evaluation link to come out. If you're claiming CME credits, please be sure to complete your evaluation, and if you're not, please still complete it, because we really want to make sure that we're meeting your needs through these sessions. And finally, we'll see you again on October 15th, again at 2 o'clock, when Dr. Elmer Dillard will be discussing the role of the medical director in a COVID-19 outbreak in skilled nursing facilities. So thank you again, and please watch. We will be sharing all of these resources in a follow-up after the session.
Thank you.
Thank you.
Thank you so much, everyone. Bye-bye.